would like to take a moment to thank the organizers of World Coma Day for having me a part of this program, and more importantly to the audience, in joining us in our shared goal of curing coma. My name is Brooke Barlow. I am a neurocritical care clinical pharmacy specialist at Memorial Hermann the Woodlands in Texas. The title of my session today is Let the Brain Rest to Recover, where we will be discussing pharmacologic induced coma for the treatment of neurologic injuries. So let's start off by discussing the most common etiologies of coma. Coma is a widely encountered condition throughout various healthcare settings and may occur in the context of acute neurologic disorders or varying degrees of critical illness. However, the challenging part in clinical practice, as I'm sure you'll hear throughout the different sessions today, is that there are varying definitions and etiologies of coma that exist, making the diagnosis and treatment quite challenging. In an effort to establish a baseline understanding of common clinical features, definitions, and etiologies of coma, the Neurocritical Care Society Curing Coma campaign conducted an international multidisciplinary survey that was recently published in Journal of Neurocritical Care in 2022. So this survey was completed by 258 healthcare professionals, with over 80% being physician respondents from 41 different countries. In this survey, what they found was that medically induced coma was reported as one of the leading causes of coma at 24%, and this was followed by intracranial hemorrhage, traumatic brain injury, and hypoxic ischemic encephalopathy. Note in this study, oftentimes clinicians did have varying definitions of coma, most commonly identified by the Glasgow Coma Scale or by neurologic examinations. What exactly is a medically induced coma? When it comes to talking about drug-related causes of coma, terminology does matter here. A medically induced coma uses medications to achieve a deep sedation state of brain inactivity. This is oftentimes a reversible unconsciousness state employed therapeutically to protect the brain from damage, such as in the setting of refractory intracranial hypertension and the use of a barbiturate coma. So again, oftentimes utilized for therapeutic purposes. Another term for this may be drug-induced coma. However, this is often mistaken with drug-related intoxication and a secondary coma due to illicit drug use or potential adverse reactions to medications, and the example here could be an opioid overdose. It is really important to make the clarifications to families and caregivers in defining drug or medically induced coma to minimize any confusion. The presentation today will focus on medically induced coma, why we use it, how it's done, potential risks, and expectations for recovery. When it comes to utilizing a medically induced coma for neurologic injuries, as a reminder to the audience, this is not a common procedure performed in clinical practice and is usually reserved as a last-line resort for when other options may have failed to control the underlying condition. In the setting of neurocritical care, the two most common conditions for which a medically induced coma is employed is within the setting of refractory status epilepticus and refractory intracranial hypertension, which is most often encountered in patients with a severe traumatic brain injury. In the upcoming slides, we will discuss the utilization of a medically induced coma for both of these conditions in more detail. We'll start off by discussing the treatment of refractory status epilepticus. Refractory status epilepticus is considered a neurologic emergency associated with a high degree of morbidity and mortality if left untreated. In the treatment of seizures, the telltale saying in neurocritical care remains true that time is brain, as it is estimated up to 1.9 million neurons may die each minute seizures go untreated. In the treatment algorithm, benzodiazepines continue to be recommended as the first-line treatment options for seizures, and this may include an agent such as lorazepam or midazolam. However, it is estimated up to 30% of patients may fail to respond to initial treatment, warranting initiation of second-line therapies such as levetiracetam, valproic acid, or fosphenytoin. However, if seizures fail to terminate despite adequately dosed first and second-line therapies, patients are considered to be in refractory status epilepticus, which is estimated to occur in up to 10 to 30% of patients may progress to this refractory stage. For these patients, intravenous anesthetics are recommended for refractory status epilepticus. However, these do come with requiring intubation, mechanical ventilation, and ICU admission. It is important to note both the appropriate dosing of medications as well as the rapid initiation of therapy is crucial for the termination of status epilepticus. In patients with refractory status epilepticus, we know the typical response rate to anti-seizure medications used for urgent therapy, such as benzodiazepines, are typically less than 20%. Now, this high failure rate is in part due to the receptor alterations that occur in the progression of status epilepticus. Under normal conditions, as demonstrated by the neuron and synapse on this slide, we are normally in a state of homeostasis with respect to excitatory glutamatergic transmission and inhibitory GABAergic activity. However, as seizures progress in prolonged status epilepticus, such as refractory status epilepticus, NMDA receptors begin to upregulate on the postsynaptic surface, causing the increased excitation coupled with GABA receptor endocytosis, further perpetuating the excitatory imbalance. In animal studies of status epilepticus, benzodiazepine receptors again undergo that endocytosis after about 30 minutes of prolonged status epilepticus, leading to a benzodiazepine refractory state. The increase in NMDA glutamatergic expression leads to an increased excitatory state in the brain, again that perpetuates status epilepticus and increases the cerebral metabolic needs. Treatment of refractory status epilepticus therefore requires overcoming the receptor alterations we discussed in the previous slide. And this can include targeting NMDA overexpression or enhancing the inhibitory effect of the remaining GABA receptors, and decreasing cerebral metabolic activity through inducing burst suppression. Therefore, the traditional treatment options for refractory status epilepticus consist of inducing a pharmacologic coma with the goal of achieving isoelectric EEG or burst suppression, halting electrographic seizure activity. Several agents have been utilized in the setting of refractory status epilepticus, including the agents listed on the slide, such as propofol, ketamine, midazolam, and pentobarbital. With the use of these agents, however, they do come with significant adverse effects to be aware of. So propofol, as listed on the left-hand side, is oftentimes utilized for refractory status epilepticus. It is a GABA agonist and also has some off-targeted NMDA antagonistic activity. You can see the doses listed on the slide here, with doses for refractory status epilepticus going as high as 200 micrograms per kilogram per minute. The benefit of utilizing propofol is that it does have a rapid onset and a short duration of action, therefore warranting rapid titration, as well as when discontinuing the agent, you would not expect prolonged effects. However, propofol does come with significant adverse effects as it is formulated as a lipid emulsion. This, with prolonged high doses, can induce propofol-related infusion syndrome, hypertriglyceridemia, and hypotension is often seen with these high doses, which can quickly lead to cardiovascular collapse and death if not recognized, most commonly associated with, again, the propofol-related infusion syndrome. So ketamine is also an emerging option as it does target the overexpression of NMDA activity seen in refractory status epilepticus. However, it is important to note that it does not achieve burst suppression even at high doses, so oftentimes requiring to be utilized as an adjunct agent to some of the other agents listed on the slide. For ketamine, it does have the benefit where it would not induce hypotension compared to some of the other agents on this slide, given the induction increase in catecholamine response seen with the initiation of ketamine. So it can cause hypertension in these cases. However, some other adverse effects to be aware of are hypersalivation, hallucinations, and then the emergence reaction after discontinuation. Midazolam is a benzodiazepine utilized at high doses when employed for refractory status epilepticus. As we discussed, traditional benzodiazepine doses are ineffective for the treatment of refractory status epilepticus. So it is important to note on the slide that this is a milligram per kilogram per hour dosing, going as high as 2.9 mg per kg per hour in some cases of refractory status. Again, that's to overcome that downregulation of GABA activity. With midazolam, it's important to note it does have a relatively long half-life, which can accumulate in both hepatic and renal impairment, as it does have an active metabolite. Patients that receive midazolam also may develop tachyphylaxis with prolonged use because, as we discussed, patients do fail to respond to benzodiazepine type therapy. And then finally, we have pentobarbital, which is a barbiturate, and it does differ in the than traditional benzodiazepines in that it prolongs the duration of GABA receptor signaling and that chloride influx, which we'll discuss more in the next coming slides. But it is proposed to have improved seizure activity compared to some of the other traditional GABA agents. This drug is hepatically metabolized and does have a very prolonged half-life, and in some cases up to 50 hours with prolonged use. This agent is also associated with a significant amount of adverse effects, which we will discuss in upcoming slides, which is important to consider when thinking about initiating this therapy for refractory status epilepticus. Titrating the anesthetic agents to burst suppression and halting electrographic seizure activity are acceptable goals. However, practically speaking, titrating to seizure cessation would ideally seem to be the optimal goal and lead to less drug exposure. However, in several patients, seizure control does not occur without achieving isoelectric EEG or identified as burst suppression, as showed on this slide. So burst suppression itself is defined as a continuous alterations between high voltage slow waves and depressed electrographic activity, which is the pattern, again, that associated with a medically induced coma or pharmacologic induced coma. These agents should ideally be titrated when achieving burst suppression to achieve 1 to 2 bursts every 10 seconds. The duration of this type of therapy really depends on patient response to the treatment, but generally is recommended to be continued for at least 24 to 48 hours after seizure cessation, and then subsequently would be followed by a slow, controlled wean, again to prevent the risk of seizure reoccurrence. There is limited data that exists outlining the preferred agent for burst suppression in refractory status epilepticus, as little prospective data is available to compare these agents directly. However, there was a meta-analysis conducted that compared midazolam, propofol, and pentobarbital for patients with refractory status epilepticus. In the primary outcome of achievement of burst suppression compared to seizure control, burst suppression did decrease the risk of breakthrough seizures, but did increase the incidence of adverse effects such as hypotension compared to seizure control alone. When comparing the agents directly, pentobarbital was associated with a reduced incidence of acute failure rate, reduced breakthrough and withdrawal seizures, as well as a reduced need to switch to an alternative anti-seizure medication. However, as anticipated, we know pentobarbital comes with a myriad of adverse effects, and this agent was associated with an increased risk of hypotension, delayed awakening, and duration of mechanical ventilation. Midazolam is oftentimes employed in clinical practice. However, based on this meta-analysis, they did find that midazolam did have an increased risk of breakthrough seizures and a need to switch to an alternative anti-seizure medication. However, adverse effect profile of midazolam, it was better tolerated with a reduced incidence of hypotension. As we discussed, inducing a pharmacologic coma is often reserved for last-line treatment, as it is associated with a very high morbidity and mortality rate in these patients that do require burst suppression for RSE. This might be due to selection bias based on some of the studies, as it is reserved for last-line refractory disease. However, more research is needed to define the precise role of burst suppression and intravenous anesthetics in the treatment of refractory status epilepticus, particularly in respect to the timing of initiation and, again, the impact on neurologic outcome for these patients. So let's switch gears and quickly discuss the utilization of a pharmacologic coma for intracranial hypertension in the setting of traumatic brain injury. But first, it's important to understand underlying concepts such as the Monroe-Kelly doctrine. This doctrine states that the cranium is a rigid structure and formed of 3 major components as outlined in this image here. So we have the blood, the cerebral spinal fluid, and the cerebral parenchyma. The volume of each one of these intracranial contents remains constant. If the addition of a mass or hematoma resulting in the squeeze or equal outflow of both CSF and venous blood, the ICP in these cases would remain normal in a compensated state, examined by the second image in this slide. Now, when we go to the very bottom image, we see the uncompensated state of increased intracranial pressure that can occur in the setting of traumatic brain injury or other types of neurologic injuries. So this occurs when the compensatory mechanism is exhausted. There is an exponential increase in ICP for even a small increase in volume, such as a hematoma or a brain mass, which may ultimately reduce brain perfusion. So again, traumatic brain injuries often result in significant swelling of the brain. This swelling puts pressure and reduces blood flow, oxygen supply, and can damage this brain tissue. Now, looking at another core concept is cerebral autoregulation, and this normally protects the brain against changes in cerebral perfusion pressure by adjusting the vascular resistance to ensure a steady cerebral blood flow. Again, in normal conditions, our CPP remains constant over a wide range of blood pressures. However, when the MAP is elevated, vasoconstriction can occur to limit blood flow to maintain, again, a normal CPP. When the MAP, however, subsequently, if a patient becomes hypotensive, the cerebral vasculature dilates to increase blood flow and maintain a normal cerebral perfusion pressure. In traumatic brain injury, however, this ICP does go unregulated, as it does with autoregulation. In these patients, we do see that cerebral autoregulatory processes are impaired, and there becomes a direct relationship between MAP and cerebral blood flow, with either ischemia or hyperemia occurring with even small changes in blood pressure. Elevated ICP, again coupled with impaired cerebral autoregulation and TBI, can result in cerebral hypoxia and secondary brain injury. So in these patients that develop an elevated intracranial pressure in the setting of a traumatic brain injury, our goal again is to balance the cerebral perfusion pressure while reducing ICP. The traumatic brain injury guidelines have developed a tiered-based system to again balance the benefits and risks associated with different agents, with movement to higher tiers reflecting more aggressive interventions that may be associated with higher risks. So the goal of Tier 1 therapies is to establish a stable neuroprotective physiologic baseline, and this is regardless of ICP readings. This shouldn't be employed with analgesia and sedation, mild hypocapnia, and initiation of normothermia and euvolemia. When we move to Tier 2 therapies, you can initiate treatment for ICP that may include osmotherapy, CSF diversion, or increased analgesia and sedation. However, in patients that fail to respond to these initial therapies may require more deep sedation and neuromuscular blockade. Finally, when we get to Tier 4 treatments, they are associated with the greatest risks, and this may include surgical intervention with a decompressive hemicraniotomy, hypothermia, or even a barbiturate coma to induce burst suppression. Barbiturate comas for refractory intracranial hypertension in the setting of traumatic brain injuries have been employed for over 60 years in these critically ill neurologic patients, with their proposed mechanism to be neuroprotective properties, and this can include through coupling of cerebral blood flow to regional cerebral metabolic demands. The decreased cerebral metabolic requirement would lower, therefore, cerebral blood volume, which in turn can result in a lower ICP. Other mechanisms may include inhibition of free radical-mediated lipid peroxidation and amelioration of glutamate release. As you can see, based on the pharmacokinetics we discussed previously, these agents are highly lipophilic and protein-bound and are associated with drug-drug interactions via the CYP P450 mechanism, as they are inducers of CYP enzymes. Pentobarbital has an estimated half-life of up to 15 to 50 hours, whereas thiopental, which is normally utilized in Europe, has a half-life of up to 40 hours. The dosing and duration may vary, but most commonly for pentobarbital is a 10 mg per kg bolus over 30 minutes, followed by 5 mg per kg per hour over 3 hours, and then a 1 mg per kg per hour maintenance rate that is titrated to achieve a targeted ICP. Again, you can consider a rebolus if necessary. The duration of therapy, there is no general agreement on the duration of a pentobarbital coma. However, certainly the duration will depend on the condition and the patient's response to initial treatment. For instance, for patients with refractory ICPs, they may have to be treated for a longer duration until the ICP has normalized, and we can again normalize the compliance, which may be several days in these patients with a TBI. Despite their long-standing use, pentobarbital or a barbiturate coma is associated with a host of serious adverse effects. And it is important to discuss and think about these different adverse effects as if they may, in some cases, mitigate the beneficial effects of therapy, specifically if hypotension occurs, as we know that this can adversely affect our cerebral perfusion pressure. So the most common adverse effects associated with a barbiturate coma may include respiratory depression, paralytic ileus, propylene glycol toxicity, given that pentobarbital, the propylene glycol is utilized as a solubilizing agent in this treatment, so high doses or prolonged therapy can induce propylene glycol toxicity. Immune suppression has also been seen with prolonged duration of barbiturate coma therapy due to the inhibition of lymphocytic activity, which can result in increased risk of pneumonia, specifically ventilator-associated pneumonia with these patients. Hepatic dysfunction can also occur, and you should be monitoring routine AST and ALT or other liver function tests to monitor for such dysfunction in therapy. With hypotension, these patients oftentimes require vasopressor support to mitigate the risk of adverse affecting cerebral perfusion pressure, as this should be maintained, as we said, above 60 to ensure that the brain is being adequately perfused. And paralytic ileus, these patients oftentimes do have feeding intolerance, and we may have to employ post-pyloric feeds, or if not tolerated, these patients may require TPN while maintained on barbiturate therapy. Whether deep sedation is used in the setting of refractory status epilepticus or refractory intracranial hypertension, the prolonged deep sedation employed for these therapies and potential drug accumulation can be harmful in ICU patients, and in general may complicate the matters in clinicians who wish to evaluate the potential deficits in neurologic function as the pharmacologically induced coma does subside. So the high doses of specifically lipophilic agents such as midazolam or propofol can lead to drug accumulation and a prolongation in the context-sensitive half-life, which is defined as the time required for the concentration in plasma to reduce by around 50% after infusion discontinuation. You can see, based on the image on this slide, fentanyl, thiopental, as well as midazolam do have increased and prolonged infusion context-sensitive half-life based on the duration of these infusions. Again, which may complicate the matters when evaluating the patient as the pharmacologically induced coma is discontinued. Notably, midazolam's half-life is prolonged to up to 24 hours in some cases of refractory status epilepticus, which may be further impaired if the patient does have hepatic or renal dysfunction. So just important to note that once sedation is discontinued, patients may require a prolonged duration for awakening and to evaluate their neurologic status based on this context-sensitive half-life. So unfortunately, there is no one-size-fits-all approach when estimating the time to awakening after discontinuation of a pharmacologically induced coma. However, some general principles can be thought about when trying to make this estimation. It is generally recommended to wait 5 elimination half-lives to consider the drug to be out of the body or no longer present its pharmacologic activity. But things to consider is presence of renal failure, which may prolong midazolam and its pharmacologically active metabolite, as well as hepatic failure that can increase pentobarbital activity. You can consider estimating plasma drug levels when present. However, it is not known whether or not the drug levels present may still include some of the pharmacologic activity, but pentobarbital in this case may be, you may be able to obtain serum levels with a level of less than 10 generally be considered subtherapeutic. Urine drug monitoring is not recommended in these cases due to the risk of a potential false positive, as the metabolites of various agents such as benzodiazepines may remain positive for several days following exposure and may not accurately reflect the pharmacologic activity of these agents within the plasma. And when you have an unknown half-life or no drug levels may be present, ancillary testing of blood flow or imaging can be considered in these cases. So hopefully you are well informed about pharmacologically induced coma for various neurologic injuries in the setting of neurocritical care. I'd like to thank again the organizers of World Coma Day for having me a part of this session, and thanks again to the audience for joining us in Curing Coma.